So it's a great privilege, a great honour to be here, and it's lovely to be back in Norway. Thank you for arranging the coldness. It makes me realise that I am, in fact, in Norway. It was very difficult to follow Anne-Christine's talk. I'm sure it was very good. I followed some bits of it, and I'll refer to some parts of it in my own talk. But regardless of that, I think what I can feel is kind of energy and optimism. There's some enthusiasm about the future in the room, and I can kind of feel it. It's tangible, and it's wonderful. You know, we're in the middle of recession, worldwide recession, and yet people are thinking very positively about what we can do in terms of making nursing care better and nursing practice better. So I have multiple roles. One of them, I'm a professor of nursing and health informatics at the University of Salford. I'm also currently the director of the eHealth programme at the International Council of Nurses. And I'll talk a little bit about the eHealth programme in terms of background and context. The title of my talk, Great Nurses Need Great Systems. Another way of looking at it is Great Systems Need Great Nurses. And I think that towards the end of my talk, I'll refer a little bit to this. I believe lunch is at 1, so I've planned for half an hour of talking, so I'll talk very slowly. No, I mean, we can use the time. If we have extra time at the end, then we can use the time for discussion.
But lunch will not be served until 1 o'clock, no matter what.
So it's rare that you get motivated, like-minded people in the same room at the same time, and so we can use that time, I'm sure. In terms of the outline of my talk, I'll talk about some of my own personal motivation for being in this kind of field of work. I'll provide some background, some context, mainly to talk about a couple of examples of systems that are used in Portugal, one from Portugal, one from the autonomous region of Madeira. And then there'll be time for questions. So the examples are, I'm going to try and show how standardized terminology is used within really good software to improve data capture, workflow, decision-making, and reuse of data, specifically reuse of data. Those who've seen recent talks by me will have seen these pictures before. So this is about why I'm motivated to be working in eHealth in particular. We're used to seeing the world in terms of land area, so this is a kind of familiar map of the world. I don't know why Norway's so thin at the top, but so this is how we're used to seeing the world in terms of kind of geographical regions. Some clever people in Sheffield, in England, developed a way of kind of transforming the map according to different criteria. One of those is the proportion of young people living with HIV. And if you go on those criteria, the shape of the world completely changes. So Africa, as we might imagine, particularly not the northern African countries, but the middle and southern African countries bloat out of recognition. India's huge. Then countries like the USA, Japan, Australia virtually disappear. If we now look at the world in terms of the proportion of nurses working across the world, it's an entirely different shape, almost the inverse of the... So that those with the greatest need have the fewest resources to meet those needs. And if I'll just animate it so you can see the stark differences in the different regions in the world. So that's HIV. We can also look in terms of TB, and it's a similar story. Slightly different transformation, but India's huge, China's huge. I'm not sure what's happening with Russia there, because I know that there is an emerging big problem in Russia with TB, particularly multiple drug-resistant TB. But it's probably based on old statistics. And again, an animation gives you an idea of the kind of disparity. Okay, there's some context. I work in Salford, which is a former industrial town in the north of England, right next door to Manchester. This is a picture of my office. One commentator said, "The workers of Salford," that's me, "live in dwellings in which cleanliness and comfort are impossible." This was Friedrich Engels, who went on to write the Communist Manifesto with Karl Marx, and much of the basic research was done around Salford and parts of Manchester. So it has been a terrible place to live in the past. It still is to some extent. There's still a lot of poverty. There's also a lot of wealth, and this is what's now called Media City, which is an area in the nice part of Salford, where a lot of money's gone in there, and the parts of the BBC have moved there. If you turn round, I don't know if anyone's been to see Manchester United play, but if you turn round and look over there, the Stretford end of Old Trafford is just there. So this, you know who this is. This is Florence by the Bosphorus. Florence Nightingale, it still amazes me. Every time I read this, it still amazes me. 150 years ago, in attempting to arrive at the truth, I've applied everywhere for information, but in scarcely an instance have I been able to obtain hospital records fit for any purposes of comparison. So this really is the birth of epidemiology. Basically what she was saying, I guess, is that better information leads to, or is linked to better healthcare. Slightly more recently, this is another person writing, "Today, the nursing shortage being what it is, every effort should be made to utilise our nurses to the utmost and not take their time with clerical work of no immediate value." That'll resonate with some of you, and it did when it was written over 50 years ago. So this has been a problem for a long time. Nursing records have been a problem for a long time. So if you think of, you combine the kind of health inequalities, the lack of equity, lack of access, poor access across the world, with information, the need for information, good information to improve care, and the fact that nurses are documenting sometimes in an unproductive way. This is where I think that eHealth can come in. So partly this is what this meeting's about. eHealth, the International Council of Nurses uses the World Health Organization description of eHealth, which is a very broad, intentionally broad. It's about IT in healthcare, for whatever reason, for treating patients, for educating, for tracking diseases, for doing research, for monitoring public health. And examples, you'll have seen examples this morning, you'll see more over the next day and a half. Electronic patient records, telehealth and telecare decision support, patient information portals, social networking sites, and the things that we can't imagine that are just around the corner. I think there's a need to manage expectations, not just amongst ourselves, not just amongst nursing profession, but also to the outside world as well. eHealth, we can be optimistic about the future of eHealth, but we also need to be a little bit cagey about managing people's expectations. So we don't talk about eLife. We do talk about eHealth still. In the future, we may just talk about health. Banking, I no longer say e-banking. It's just banking. I don't know how to do banking if I don't do it online. The same with shopping now. I very rarely go to shops. I certainly wouldn't know how to book travel if I didn't do it on the web. I remember going in and filling out forms in the back of holiday brochures and handing them in and waiting to see whether you'd got a place or not. But they're just part of everyday life. But ATMs, for example, haven't improved my financial status. I still go overdrawn. Web TV hasn't made me like certain programs. I don't like EastEnders. Do you get EastEnders over here? Yeah. I still don't like it. Sat-navs haven't made me my journey safer. I still crash the car. And online travel doesn't make the sunshine when I go on holiday. But I can't live without them. I couldn't live without them, and many of you can't live without these things. So my own personal vision is that eHealth systems are in absolute routine use to parallel other aspects of our life. And the data derived from the systems is available and routinely used to make for the benefit of patients and the people that care for them, to improve patient care and nursing practice. And that people are actively working on improving how things are, advancing the science, if you like, and many of you will be contributing actively to that. So I mentioned one of my roles is at the University of Salford. Another role is with the International Council of Nurses as the eHealth Programme Director. If you don't know, the ICN is a federation of nursing organisations across the world, over 130 national nurses associations, including the Norwegian Nurses Organisation, representing round about 13 million nurses by proxy. It's run by nurses, operated by nurses, and it's been around for a long time. It's the oldest international health professional organisation. And its purpose is to represent nursing, to advance the profession, advance nursing, and to influence policy worldwide. So we have an eHealth programme. We announced it last year at the conference, ICN conference in Malta. It's been brewing for a long time, about 20 years, and the mission is to transform nursing through the visionary application of information and communication technology. So why is ICN interested in eHealth? It's kind of obvious. The proliferation of ICT, the opportunities for kind of addressing health inequalities and improving access to healthcare. And ICN is an advocacy organisation. It advocates for nursing and its members, so it makes sense that it should be centrally involved in this space. And eHealth threads through the ICN processes themselves, so it's important for the business of ICN itself that it uses eHealth. There are 3 work streams, very briefly. Connecting Nurses is an initiative supported by Sanofi, and it's a moderated social network for nurses to share resources, to share ideas and innovations, and then to pass on those innovations to patients. We also oversee the ICN Telenursing Network, which is a global resource for sharing knowledge specifically about telehealth and telecare. And the third, probably the biggest function that we have is the International Classification for Nursing Practice Programme, which this is very similar to one of Anne-Christine's slides about ICNP. ICN's been supporting ICNP for a long time, and it basically is a standardised terminology which you'll have seen before. A language is the phrases, the words and phrases that nurses use in practice to describe their practice and to describe the condition of patients. It's available in 14 languages, including Norwegian. Norwegian's always the most up-to-date, most timely translation, thanks to a couple of people in this room. So thank you very much we realise the amount of effort it takes to translate, and it's very valuable to us. ICNP is a related classification in the World Health Organization family of international classifications. That family includes ICD, the International Classification of Diseases, ICF, International Classification of Functioning. And we have collaborative agreements in place with the International Health Terminology Standards Development Organisation, which oversees the development of SNOMED, and Sabacare, Virginia Saber, who heads up that organisation to oversee the development of CCC, the Clinical Care Classification.
Nick, I would think most of these people are not familiar with all of this, just so you know.
You are familiar.
Huh?
You are familiar or not familiar?
Not.
Okay, so it's a lot of acronyms. Yeah. So these are different terminologies, and ICN has agreements with the developers of those vocabularies so that we're aligned. So we don't develop something that contradicts what's being developed by another organisation. At ICN, we're interested in giving nurses the tools that they need, the best tools that they can have to do their job most effectively. To some extent, we don't care what it is. We're precious about ICNP, that's our product, but it's not a competition. This is about giving nurses what they need. So we like to collaborate, we seek collaboration, and so these harmonisation agreements are really important to us. The mappings bullet point is simply it's a technique for ensuring that people that use ICMP aren't isolated from the wider informatics community. So if, for example, we in the UK choose to use SNOMED CT, the mappings exist so that nurses using ICMP can relate to those people using another terminology. So in terms of the application and development of ICMP, there's a number of techniques that we use, a number of systems, a number of processes. There are individual collaborative research and development projects happening across the world. We have 10 ICMP research and development centres who contribute on a voluntary basis to the programme. And then we support practical use at the point of care through the translation activity to make sure that people can engage with the terminology through catalogue development. These are subsets of terms used for a particular clinical topic, clinical area. And we're starting on research into care planning. Most interesting for this meeting is probably that we have commercial agreements with software suppliers. The implementation is the interesting thing. And so we've developed ICMP, we continue to maintain ICMP, but we're much more interested now in implementation, exploitation, if you like, of ICMP. So getting it into practice and getting it used and getting the information so it can support practice. So I want to present a couple of examples. The first one it came out of the nursing school in Porto, and it's a relatively straightforward system that takes a basic kind of record system one step further, in that it introduces a kind of workflow through this kind of cascading dialogue. So the process simply is that a nurse decides a kind of focus area, a topic area. They perform some diagnostic interventions which are suggested by the system. The system then suggests a likely diagnosis, and then the system also, once you've selected that diagnosis, suggests possible interventions that would address the diagnosis. So this is a real system. The look and feel it looks kind of old-fashioned to me. It's quite incredible how fast things move. This is an existing system, though. So this is a list of fictitious patients, pretty familiar to people who've used record systems. But a nurse would go into the nursing process space and select an area of interest. In this case, is confusion. And then once they're thinking about I wanted to record something about this patient's confusion, then they select a number of diagnostic interventions. And once they've selected the diagnostic intervention, so this is kind of an assessment, is what assessment actions am I going to take for this patient? Then the system itself suggests a possible diagnosis. Once the nurse has selected a possible diagnosis, in this case risk of confusion, then the system takes that information and suggests interventions. And this is probably something that Anne-Christine was talking about in her talk. So what kind of interventions, it's not saying you must do these interventions. This is a record system. So this isn't a kind of protocol. This is just saying, here are some likely interventions that you might do for this diagnosis. To some extent, it's cutting down the kind of search space. But it's also guiding practice. It's also supporting decision-making. And then once you've selected the interventions, you can do timings and fancy things like that and produce a care plan with the timings, essentially a task list, which I'm not very keen on, but that's how they practice in that particular environment. With timings, and you can click them when you've done them. So that's a relatively straightforward, simple system that's about improving data capture, improving workflow, and actually guiding practice. So in guiding decision making. The next example's from Madeira. This is more about data reuse. And so the added ingredient here is outcomes, expected outcomes and actual results. So in Madeira, this is linked to the slide from Póvoa that Anne-Christine had on, which was looking at effectiveness, relative effectiveness. So in Madeira, they decided on a number of indicators which they would like to keep an eye on for particular areas of practice. So, and they've arranged those in terms of structure, process, and outcome. So the structure indicators are things like the number of hours spent per patient per day. The process indicators, one of them is risk identification, which is the number of cases that have a documented risk that have gone on to develop a problem as a ratio of the cases that have gone on to develop a problem. So essentially what this is answering is, did the identification of a risk help to prevent the problem from happening? It's nothing about doing, it's just identifying the risk, did that stop the problem? In terms of outcome indicators, one of them is the number of cases where a problem was resolved when we'd done something about it as a ratio of the number of cases of that problem. So this is essentially saying, did our actions help to resolve a problem? Did what we do make a difference? Then another outcome indicator is about prevention of problems. So the number of cases with the risk of a specified problem that didn't develop that problem that we did something about, over the number of cases with the risk of that problem. So this is saying, did our actions help to prevent a problem? This is very interesting for nursing, because a lot of our work, a lot of the hidden work, is about preventing bad things from happening. And then another one is about achieving expected outcomes. So this is about expected outcomes. It's not about necessarily problem resolution. It's about, did our actions help to resolve help to achieve an expected outcome? So the quite sophisticated, quite rich data requirements to be able to answer those questions. Things not just diagnosis, intervention, but also risk, expected outcome, actual outcome. And that's reflected in the system and the data collection for the system. So they've agreed on key areas for particular areas of practice, key elements for particular areas of practice. So some examples for adult care are falls, dehydration, pain, aspiration. I'm almost certain pressure sores will be in there as well. And then they kind of drill down and apply, so those, the ratios that I showed you before, they're kind of applied as a matrix. So they look at key indicators that they'd like to monitor, risk for aspiration, and then they use, in this case, the risk identification ratio, and they decide when they're going to collect that data. So this is all in advance, agreed in advance, but behind the scenes. This is nothing that practicing nurses have to worry themselves about. Their job is to provide nursing care and provide the data that supports that care. So all of these are done as a byproduct of the recording process. The system, so this is the front end of the system. This is for a particular person, a list of diagnoses and a list of interventions. Again, quite familiar for people who've used record systems. The difference is that there are, sorry about the resolution, the difference is that the right-hand side is about outcomes. It's about expected outcomes and results. So here, with indications of whether you've achieved an expected outcome or whether you've resolved a problem or not. And what that gives you is the ability to do those to build those kind of indicators and do those get that kind of statistical data. So here's quite simple epidemiological indicators, they call them, but this is just a simple kind of incidence, if you like, frequency count of particular diagnoses. The one highlighted as confusion as the topic area, the focus, and then the diagnoses themselves gives you the number of people with a diagnosis of actual confusion, and that can be compared across different services. And obviously it can be shown in different formats as well, so you can look at different services and see what characterises those services. And the same can be done also for interventions. This relates to some very exciting, long-standing work in Belgium on the nursing minimum data set in Belgium, where different units are characterised according to the interventions that are carried out within those units. But even more exciting is that it allows you to do things like risk identification for particular topic areas, prevention of problems for particular topic areas. So you can then look at, did what we do make a difference? Either did we resolve a problem, or did we stop a risk from becoming into an actual problem? Similarly, with resolving problems and achieving expected outcomes. And I had the good fortune of visiting the hospital. Clarice Martins is the head nurse there in Papua that Anne-Christine showed the information for. And she, in her presentation, she went beyond those simple tables. She had a kind of dashboard, and it was live. She was demonstrating it to us live, and she could pick out where an intervention hadn't been carried out, where there was a patient at risk of developing something. And not only that, she could identify the nurse who hadn't done the intervention. And it's a relatively small hospital, so if she saw that, she herself would go down and talk to the nurse and ask why the intervention wasn't carried out. It's very powerful, and that's on a day-to-day, minute-to-minute level. Never mind all of the kind of statistics and the trends over years. This is, from one shift to the next. So, it's both threatening and exciting at the same time. So that's a couple of glimpses of a couple of systems. Kind of augments, I think, what Anne-Christine said. Absolutely, it depends on there being a standard terminology. Those, in particular, were ICNP. It doesn't have to be ICNP. They also rely on a good implementation. So there has to be that vision in the first place. Once there is that vision in the first place, for example, the hospital in Papua had no problem with data collection because the nurses themselves could see the benefit it was instantaneous, the benefit of the data collection. And both of those things are important for data capture, as I said, to support workflow, to support decision making, and for data reuse. So I'd say, even though Florence Nightingale wrote 150 years ago, she was kind of writing in the medical world. Nursing's, this is quite new to nursing. We're new at it, but we're making significant advances, and really quite rapidly. Portugal's very fortunate. They had a mandated national terminology, and they've had it for about a decade or more. And so it's not surprising that a lot of that kind of fairly cutting-edge work is coming out of Portugal, because they've got the experience of using it. But that means that we can benefit off that. They've done that hard learning, and we can benefit off that now. It helps if you speak Portuguese, of course. So that's why the alternative title to my talk, The Great Systems Need Great Nurses. I'm sure all of you are great nurses, so just go and do it.